Hello students, I am Dr. Narendran. I am Associate Professor from Department of Oral Maxillofacial Surgery. I am from Vinaya Mission Sankaracharya Dental College, Salem. So today I am going to talk about maxillary nerve blocks. So usually you know about nerve blocks. All of you need to know about nerve blocks because a nerve block is the main thing that you need to do before extraction. Either it will be from maxilla and mandible. There are mainly two nerve blocks, two set of sections. So first today here I am going to tell about maxillary nerve block. So I always start up with a proverb like never stop believing in hopes, miracles happen every day. So always have an hope always when you start up your day. So local anesthesia is a maxillary region related to maxillary division of trigeminal nerve. So first I'll tell you about maxillary nerve blocks. Maxillary nerve blocks, there are totally about 5 maxillary nerve blocks are there. Okay, so you have the anterior superior nerve block, posterior superior nerve block and middle superior nerve block. And when you come to the palatal side, you have greater palatine and the nasopalatine. These are the 5 nerve blocks mainly that is available in the maxillary nerve. So when you are anesthetizing any tooth in the maxilla, these are the 5 blocks that you are going to be using it. Or if it is a mobile tooth, you will be using in local infiltration. Okay, other than that, these are the 5 nerve blocks that you mainly will be using. Okay, so if you know these 5 nerve blocks, you need not worry about anything about extraction, or you can confidently proceed with your nerve blocks. So first thing is posterior superior nerve block, one of frequently used nerve blocks in dentistry. So it is the anesthetic solution is deposited behind the tuberosity near the posterior superior nerve before it enters the maxillary sinus. So first, what are the main nerve? See, if you can remember these nerve blocks by remembering the nerves, the nerve supply of each tooth. So each tooth has a nerve supply. So in the posterior superior nerve is the main nerve supply of the posterior most tooth of the maxillary region. So same nerve block you are going to give. So it is very simple to understand. So PSA, it is shortly called as PSA. So posterior superior nerve block is otherwise known as a tuberosity block or zygomatic block used to achieve anesthesia to maxillary molar teeth up to the first molar, with the exception of mesiobuccal in some cases. Okay, except the mesiobuccal root of the first molar, rest all the molars will be anesthetized in this nerve block. Okay, maybe the 7, the 8 and except the mesiobuccal root of the first molar. So one of the potential complication of this technique is hematoma. The formation from the injection in anesthetic into the pterygoid plexus of veins and accidental puncture of the maxillary artery. So why this hematoma happens? Because this happens mainly because when you puncture the pterygoid plexus of veins. Okay, this is one of the important vein which you find in this region. So when you go more deeper or you take a longer needle through this part, you might puncture that. There's nothing going to happen with it, but there'll be a hematoma formation. You'll not be scared of it, or you'll not be worried about that. So there'll be, you just give a pressure pack, automatically the bleeding will be stopped. Okay, so it is you cannot be suddenly scared suddenly when you have heavy bleeding this happens only when you have a very long needle or you go very deep and puncture the pterygoid plexus. So most common complication, it could be like pterygoid plexus of veins, that is hematoma. So always aspirate before you inject it. Okay, when you insert the injection, please aspirate and then you inject. The indication for the technique is need to anesthetize multiple molar tooths. Okay, so in individuals with coagulation disorders, care must be taken not to avoid the injury of pterygoid plexus of veins, or the 25 or 27 gauge of needle is preferred mostly. Okay, so technique, how do you give this nerve block? So identify the height of the mucobuccal fold over the second molar. So second molar will be your injection site. Okay, so you have your second molar is the injection site, and from injection site there will be an injection. You give it in 45 degree of angulations. The right-handed operator should stand in 9 o'clock position, whereas the left-handed operator should be staying in 2 o'clock position, and retract the lip and retract the instrument. Hold the syringe, the bevel towards the bone. You know what is the bevel, right? So when the syringe, the bevel should be facing the bone. Insert the needle at the height of the mucobuccal fold above the maxillary second molar at 45 degrees angle, directed superiorly, medially and posteriorly. Okay, remember that, superiorly, medially and posteriorly. Advance the needle to a depth of 3/4 and of its total length. Okay, the needle 3/4 of the total length of the needle should be inserted and it should be injected. Okay, always aspirate and inject it in 45 degrees. So it is very simple. Your landmark will be your second molar. Okay, second molar, and your injection site will be in 45 degrees. You will be superiorly, medially and posteriorly inserting. It is on one continuous movement, not like you do not retract it each time and put it. It is on one continuous movement when you insert it. So no resistance should be felt advancing the needle through the soft tissue. There should not be any resistance. You feel like any resistance is there, you just remove it and reinsert it again on the different direction. If a bone is contacted, the medial angulation is too great. Slowly retract the needle without removing it and bring the syringe bevel towards the occlusal plane. This allows the needle to angulate slightly more to the lateral to the posterior aspect of the maxilla. Prior to injecting, one should aspirate two planes to avoid accidental injection of pterygoid plexus. After this, the first aspiration needle should be rotated 1/4 turn. The operator should then re-aspirate. If positive aspiration, slowly retract the needle in 1 to 2 millimeters and re-aspirate into two planes. So what do you mean with positive aspiration? Is like when you aspirate blood in that, you have to reinsert it. Okay. Successful injection technique will result in anesthesia of the maxillary molars, with the exception of mesiobuccal root of the first molar in some cases and associated soft tissues of the buccal aspect. So complications, as I've told you already, I've told you the complications. That is hematoma. This is commonly produced by inserting the needle too far posteriorly into the pterygoid plexus of veins. In addition, maxillary artery can be perforated. Use of short needle minimize the risk of pterygoid plexus of puncture. So that's all on posterior superior nerve block. Now the second nerve block that we are going to see is middle superior. So I'll recap the posterior superior nerve block. Except mesiobuccal of the first molar, rest all the 7 and 8 and the first molar 6 is except mesiobuccal of 6 molar. All these 3 molars will be anesthetized in the posterior superior nerve block. So now we are going into the middle superior nerve block, is also called as the MSA. The middle superior nerve block is useful procedure where the maxillary premolar teeth or mesiobuccal root of the first molar require anesthesia. So here in PSC you have left the mesiobuccal first row, that will be anesthetized in this MSA. Okay, that is in the middle superior nerve. So although not always present, it is useful to a posterior superior or alveolar nerve block to supraperiosteal infiltration fails to achieve adequate anesthesia for this technique. Individuals in whom MSA nerve is absent, the PSA and ASA nerves provide innervation to the maxillary premolar teeth and mesiobuccal root of the first molar. So here mainly you are anesthetizing the 2 premolars and the mesiobuccal root of the first molar. Okay, so sometimes there are studies saying that there could be the absence of MSA or ASA. If there is an MSA nerve block is missing in that particular area, then you have to give the PSA and ASA on that. Okay, so you need to give posterior superior nerve block and anterior superior nerve block if the MSA is missing. So suppose, how do you find out when you give a MSA nerve block and the patient doesn't respond, a patient complains of severe pain again and again. So what do? Then you give PSA nerve block again, and then next you give ASA nerve block also, then you extract the premolar. So there is nothing wrong in giving 2 extra nerve blocks because of the same side. So sometimes if it is a rare case that it could be absent. Contraindication include acute inflammation and infection in the area of injection. The procedure involving one tooth with the local infiltration will be sufficient. Okay. So technique, how do you give it? Identify the height of the mucobuccal of the second maxillary, second premolar, then the injection site will be given. Okay, that will be your injection site. Okay, the right-handed superior operator will be 9 o'clock or 10 o'clock position, whereas the left-handed operator should be standing in 2 o'clock position or 3 o'clock position. So this is where you stand. That's why I said in the clock positions. Retract the lip with a retraction of instrument. Insert the needle until the tip is above the apex of the second premolar. So when you retract the mucobuccal fold, you have to see the apex of the second premolar. So there, for the PSA, you give it on the second molar. Here, you give it on the second premolar. Aspirate the injection solution slowly over the course of 1 minute slowly. Successfully execution of this technique provides anesthesia to the pulp, surrounding soft tissue and bone of first and second premolar teeth and the mesiobuccal root of the first molar. So here what all tooths are there? First and second premolar anesthetized and mesiobuccal root of the first molar will be anesthetized. So contraindications. So infection or inflammation in the area of injection or needle insertion is a drug deposition. Okay, so when there is an inflammation or there's inflammation on that particular area, it will be difficult or it will be taking some more time to get anesthetized or get infected. So that is why you avoid that. So that will be the most common contraindication that will come across. Next we are going into the ASA nerve block, that is anterior superior nerve block. It is also called as the infraorbital nerve block. The anterior superior nerve block is a useful technique for achieving anesthesia of the maxillary central, lateral and the canine as well as surrounding soft tissue and the buccal aspect. Okay, so this anterior superior nerve block, which all is connects, it anesthetizes incisors, lateral and the canine. On the canine space, on the buccal aspect of that particular, all these 3 tooths. Okay, this will be on ASA. In patients that do not have MSA nerve, the ASA nerve may also innervate the premolar teeth and mesiobuccal root of the first molar. So everybody, there is an everything, if ASA or MSA, if there is absence, you give an alternative block. Okay, either if this is here in this case, if the MSA is not there, they give ASA. And same way, when the MSA was missing or if you feel that it is missing, then you give ASA and PSA. Indication for the use of technique includes procedure involving multiple teeth and inadequate anesthesia from the supraperiosteal technique. So a 25 gauge needle is preferred for this technique. So technique, how do you give it? Place the patient in the supine position. Okay, so this patient should be in the supine position. So identify the height of the mucobuccal fold above the maxillary first premolar. So for this maxillary first premolar will be the injection site. So the right-handed operator should stand in the 10 o'clock position, whereas the left-handed operator should be in the 2 o'clock position. Identify the infraorbital notch on the infraorbital rim. So do you find the infraorbital notch here or infraorbital rim? Okay. The infraorbital foramen lies just inferior to the notch, usually lies in the second premolar. So slightly discomfort is felt by the patient when the digital pressure is placed on the foramen. So when you have a press over this particular area, you will find a mild discomfort on this particular area where there is an infraorbital foramen there. So okay, it is helpful but not necessary to mark the position of infraorbital foramen. So retract the lip, retraction of the instrument while noting the location of the foramen, orient the bevel of the needle towards the bone, insert the needle at the height of the mucobuccal fold of the first premolar. The syringe should be angled towards the infraorbital foramen and kept parallel with the long axis of first premolar to avoid hitting the maxillary bone prematurely. So here you can see in this picture that where it is going into from the first premolar, it goes straight into the infraorbital foramen. Okay, that will be a landmark. There is one more technique for this, that is from the maxillary anteriors, from the incisors, you go cross towards the infraorbital foramen. So here in this first premolar, it goes straight into the infraorbital foramen. Here, or you keep it from the incisors and goes towards the foramen. So these are the two techniques that you find in the ASA nerve block. The needle is advanced into the soft tissue until the bone over the roof of the foramen is contracted. After aspiration, anesthetic cartridge is deposited slowly over the course of time. So here you deposit the solution not in a forceful manner, do it deposit in a slowly. It is recommended that pressure to kept over the site of injection to facilitate the diffusion of anesthetic solution into the foramen. So you keep your fingers over that particular area till the deposition is there. So once you know the landmark, like how deep you are going also, then after that you can take off your fingers. Successful execution of this technique results in anesthesia of the lower eyelid, lateral aspect of the nose and the upper lip. So the this entire region gets anesthetized. Pulpal anesthesia of the maxillary, central and lateral canine, buccal soft tissue and bone is also achieved in certain percentages. People with the premolar teeth and the mesiobuccal root of the first molar is also anesthetized. So when there is an MSA nerve block, you get anesthetized of the entire first molar and the MSA. So now we have finished all the nerve blocks in the buccal side. So what are the nerve blocks that we have seen in the buccal side? We have seen the ASA nerve block, you have seen the MSA nerve block and you have seen the PSA nerve block. Okay, so the landmark of PSA will be your second molar, the landmark of MSA will be your second premolar, and a landmark for your ASA will be your first premolar. Okay, these are the main landmarks that you need to know. I will brush up the techniques and tooth numbers when I finish this presentation. So next we are going into the palatal side. So palatal side, what do you have? Your palatal side, there will be only two foramens. So okay, one is the nasopalatal, which is just below your incisors. Okay, central incisors. Next is the greater palatal, which you find it in the palatal region. Okay, so these are the two main foramens that you find, where you have the greater palatal nerve in the greater palatal foramen and nasopalatal nerve in the nasopalatal foramen. Okay, so now first we go into the greater palatal nerve block. So the greater palatal nerve block is useful when treatment is necessary on the palatal aspect or for maxillary premolar and molar dentition. So this is exceptionally for premolar and molar region on the palatal side. This technique targets the area of anterior to the greater palatine canal. The greater palatine nerve exits the canal and travels forward between the bone and the soft tissue of the palate. So this is where the greater palatine nerve travels. So technique. The patient should be in a supine position with the chin tilted upwards. You have the chin always should be tilted upwards so you can see the palate clearly. The visibility of the area of anesthetized. The right-handed operator should be standing in the 8 o'clock position, whereas the left-handed operator should be in the 4 o'clock position. Using a cotton swab, locate the greater palatal foramen by placing it in the palatal tissue, approximately 1 centimeter medial to the junction of second and third molar. So when you have bisecting from the second and third molar, perpendicularly you find the foramen. Okay, you find the second and third molar, you draw a line straight away like bisecting into the near the palatal region, you will find the greater palatine foramen. Sometimes you will find a mild depression over that particular area when you touch it. There will be blanching. You know what is blanching is? Blanching is when you see a finger here and you press over the particular area, you see a whitish area, your blood flows just go away there and you find a whitish region there. That is called blanching. Same way you will find it in the maxillary region. So when on that particular area you will find blanching when you give more pressure on that. Okay. While in the usual position of the foramen, it may be located slightly anterior to the posterior or to this location. Gently press the swab into the tissue until the depression is created by the foramen is felt. So I have told you already. So you will find a mild depression over that particular area. The greater approximated of 1 to 2 millimeters anterior to the foramen is a target of injection site. So you cannot give an injection or any nerve block, for instance, on directly to the foramen or the nerve, because you cannot see that. So it is a matter of approximation, and you need to know the anatomic landmark where it approximately will be there. So the greater foramen, it doesn't matter that everything that will be in this centimeter or this meter everywhere. No, it differs from person to person. I may have it in a different in 1 or 2 millimeters aside. Some other person will be having it in 1 or 2 meters. This is like mild millimeters size of difference. You cannot exactly measure or accurately say it is in this type, in this position. You cannot say it, okay, because the maxillary, the bone region or tooth, everything differs from person to person. Okay, so when you usually you see in a wash basin, when you open the tap, you say like wherever water splits, you see the water filtrating into the small cup over there, into the drainage where you have the small area where it drains out. But here exactly it is like something like this. So something, our foramen is also something like that. You find the foramen, it is not necessary that you have to give exactly into the foramen. You can give it approximately near the foramen. The LA will slowly go into the foramen. It is not necessary to give approximately. If you are giving approximately, well and good, that is not an issue. But if you are giving it on the side, it will slowly approach the foramen easily. Okay. Using a cotton swab, apply a pressure over the area of foramen until the tissue blanches. I told you what is tissue blanching is. Aim the syringe perpendicular to the injection site, which 1 or 2 millimeters anterior to the foramen. While keeping the pressure on the foramen, inject a small volume of anesthetic solution in the needle and advance through the tissue until bone is contacted. Until the bone is contacted, you just give. Even if you give 1 or 2 drops, is more than enough for the greater palatal nerve block. You cannot give in ml, at least 1 or 2 drops. Okay, because you will find over pressure over that particular area. The tissue will blanch in that area surrounding the injection site. So after the injection site, you will find the blanching before. Depth of a penetrance is usually few millimeters. Once bone is contacted, aspirate or inject the necessary solution. So immediately once you hit the bone on the palatal region, approximately that, immediately inject the solution. Resistance to deposition of anesthetic solution is normally felt by the operator. Always you find a pressure, because it is not a soft tissue. Okay, it is a bone where there is an over there is a tissue. So you will find a pressure over that area. This technique provides anesthesia to the palatal mucosa, hard palate, from first premolar anterior to the posterior region aspect to the hard palate and the midline to the medially. So water from the first premolar to the molar region, entirely the palatal region will be anesthetized in this solution. Even if there is 1 or few drops, the entire area will be anesthetized. So usually when you are taking a molar or a premolar, when you are extracting, it is necessary to give either the MSA or PSA number, but also on the palatal side you need to give a greater palatal. Otherwise, in the palatal side tissue or palatal side, when you give a rotation motion on the palatal side, the patient will be having severe pain on that. So always it is safer to give a greater palatal nerve block when you are extracting the premolar or posterior molars. Next is the nasopalatine nerve block. You know exactly where the nasopalatine is. When you look across, you find in between your central incisors. Okay, so the nasopalatine nerve block, otherwise known as the incisor nerve block, and the sphenopalatine nerve block anesthetize the nasopalatine nerves bilaterally. So this is the only part where you anesthetize bilaterally. So here you anesthetize from this canine region to canine region. So exactly this entire region gets anesthetized. Okay, so in this only, see, other nerve blocks will be like unilaterally. If you palatal side, if you are giving it on the first quadrant, you have to give a greater palatal nerve block on the first quadrant side. Or if you are going to second quadrant, you have to give it. But here, nasopalatine, if you give a single block, it will get anesthetized bilaterally. Okay, the nasopalatine nerve block, otherwise known as the incisor nerve block. So in this technique, anesthetic solution deposits in the area of the incisive foramen. So incisive, you see the incisive foramen coming through that, I have marked you, and the nerves also are there. This technique is indicated when treatment requires anesthesia of the lingual aspect of the multiple anterior teeth. So this is mainly given when you are extracting multiple teeth in the anterior region. So, okay, maybe you are extracting all the anteriors, or they are doing an alveoloplasty in the anterior region, or okay, you use this nasopalatine nerve block. The patient should be in the supine position with the chin tilted upward for the visibility of the area to be anesthetized. Okay, The right-handed operator should be at the 9 o'clock position, whereas the left-handed operator should be in the 3 o'clock position. Identify the incisive papilla. The area directly lateral to incisive papilla is the injection site. So just middle inside the anterior, the palatal region is the injection site. So here you can see the cotton swab is being applied because it will be little painful. So you use a lignocaine gel or lignocaine spray to on that before giving the injection. So insert the needle just lateral to the papilla with the bevel facing the tissue, against the tissue. Advance the needle slowly towards the incisive foramen while depositing a small volume of anesthetic and maintaining a pressure on the papilla. You will be maintaining a pressure on the papilla. I just deposit a small size. Always I told you, even in greater palatate, it is not necessary that you give a large amount of LA over that. You can just give a few drops of that particular foramen area. Once bone is contacted, retract the needle approximately 1 millimeter, aspirate and inject the anesthetic solution over the course of 30 seconds. Blanching of the surrounding tissue and resistance to the deposition of the anesthetic solution is normal. Anesthesia will be provided to the soft and hard tissues of the lingual aspect of the anterior teeth from the distal of the canine on one side to the distal of the canine to the opposite side. So when you give this anesthesia, right from 1-1, 1-2, 1-3, 2-1, 2-2, 2-3. So this all 6 tooths will be anesthetized. That is from canine to canine, the anterior tooth will be anesthetized. So actually the 5 nerves, that are the most 5 important nerve blocks which I told you. Now this is called the greater palatate canal approach. So this is used with the 25 gauge needle. The technique is place the patient in a supine position. The right-handed operator should be in the 10 o'clock position, whereas the left-handed operator should be in the 2 o'clock position. Identify the greater palatate foramen as described, the technique for the greater palatate nerve block. So the tissue directly over the greater palatate nerve block is target of injection site. So here is the simple concept is right, where you gave it on the greater palatate nerve block, I told you to approximate near the canal, not to give on the canal. But here is, you are aiming at the canal. Your aim is into the canal. Okay. This technique anesthetizes the maxillary nerves and travel through the pterygopalatine fossa of a greater palatine canal. Apply pressure over the area of a greater palatate foramen with a cotton tipped applicator. Administration of greater palatate nerve block using affirmation is technique. Once adequate palatal anesthesia is achieved, gently probe the greater palatate foramen with a tip of a needle. For the technique, the syringe should be held in the syringe and aimed at the posteriorly. It is maybe necessary to change the angulation of the needle in order to locate the foramen. Once the foramen has been located, advance the needle of the depth of 30 mm. If resistance met, withdraw the needle few millimeters and enter the different angle. So this is highly painful. So you can give a greater palatate nerve block. Okay, then you aim for the where the exactly the canal is, and then you give this greater canal nerve block. Okay, this is called greater palatine canal nerve block. So exactly you are aiming at the canal of the nerve block. So if resistance is met early on the operator, unable to advance a needle into the canal more than few millimeters, the procedure should be aborted and high tuberosity approach should be considered. If no resistance is met, penetration of the canal is successful, aspirate into 2 planes and describe previous section, slowly deposit local section. Okay, if you don't have any resistance, you directly go into the canal and give the LA. As the high tuberosity approach, the high maxilla, hemimaxilla or ipsilateral side of injection becomes unnecessary with successful execution of the technique. So this is all about my maxillary nerve block. I have told you about, I will just revise about the maxillary nerve block which I think. I have told you about 5 nerve blocks, that is anterior superior nerve block, middle superior nerve block and posterior superior nerve block. And the palatal side I have told you about tetrapalatine and greater palatine nerve block. In ASA, you anesthetize the anterior tooth right from the incisors lateral and canine. Okay, that will be your anesthetizing part, and your landmark will be a first premolar. And for the MSA, the second premolar will be an injection site, and you will be anesthetizing the first, second and premolar and the mesiobuccal root of the first molar. And in the PSA, you will be anesthetizing the 7th and 8th molar except the mesiobuccal root of the first molar. Okay, this all will be anesthetized. That will be 6, 7 and 8. Okay, these all are on the buccal side. On the palatal side, you have the nasopalatate, which anesthetize the canine to canine on the anterior region. Okay, and in the greater palatine, you anesthetize the premolar to molar region. So if you are very thorough in these 5 nerve blocks, it is easy to do any type of maxillary extractions with confidently. The patient will be without any pain, nothing, and it will be easy for you to do. Thank you so much. Thank you for watching all my videos. Thank you.